Good morning, dear colleagues. I'm here with Professor Gruzdinsky and Professor Stankov, maybe, Associate Professor. And I'm Dr. Martinov, and I'm open the session with my presentation. It's an honor for me to be here. And I will start with our experience with interesting topic, acute thrombosis and bleeding. These topics are most of the cases are separate, but this topic is interesting for me. First, okay. Okay, I'm presenting my hospital. This is Russian type emergency hospital, but we have a lot of departments which are dealing with this kind of disasters like accidents, violence, a lot of catastrophes, poisons, burns, and my task was to support them in some of the cases. In this slide you see the areas we are covered till now. 12 years my team is there, and we have a lot of cases you see traumatic, G bleeding, urology, gynecology, bleeding, and the head, because the session and the motto of this Congress is from head to toe. We cover this motto, but the neurosurgery team is covering the head, but they're working with us in our cath labs. These are some examples. This is one young referee, football referee, which was cut several times with machete, and you see the result. This is below the knee lesion, and after massive hemotransfusions, the surgeons, the traumatologists decided to see if we can help, and you see that we helped in this case. This is gunshot. You can appreciate here the projectiles, and you see the lesion of tibioperineal trunk with big pseudoaneurysm, and very elegant, I will say, decision to cover the trunk with coronary covered stent with very good result. And the last of these examples is urology, our cooperation with urology department. You see the iatrogenic with nephrostoma catheter. There's a lesion on one of the branches, and we are trying to be super selective in these cases, and with a lot of devices for neurology interventions, neurointerventions, we can appreciate the exact branch and to coil it with very good result here. Till now we have coil embolization cases for bleeding, for tumors, for AVMs, aneurysms, and covered stents. And with Gela sponge, it's additional to, especially for coil embolizations, we are in some cases we are over the coil embolization, we are performing gel sponge infusion in the vessel to seal the leakage. We have a lot of thrombosis, thromboembolic cases. Like cardiology, we are doing our work with STEMIs. We have till now above 3,000 STEMI procedures. For other mentioned diseases, stroke and acute limb ischemia, we are doing with our friends, we're performing this procedure with our friends from neurology, neurosurgery, and vascular surgery departments. We are, I think we established very good connections and very good teamwork. This is till to the moment our thrombolysis, local lysis cases. You see there are almost 300, but you know there are always double procedures. First procedure, diagnosis and putting the catheter, and the second angio checking, and if needed in maybe around 20%, we have some kind of interventions like PTA or PTA plus stenting and or thrombospiration. We have till now mechanical thrombectomy with angiojet and in some cases jet stream. For peripheral, you see 64 cases, 17 with jet stream. Jet stream was performed for thrombosis here, tough thrombosis, and you see we have some visceral, and in the past they have coronary catheter, and we have 2 coronary procedures, but they can be performed with standard coronary catheter. That's why it's a very luxury procedure with this catheter. As you see, we have growing experience, but as you see, experience is the name we give to our mistakes, as said by Oscar Wilde. And you know, every time you think that you are a superhero, the life gives you a present. This is our case that I will present with 2 problematic situations, thrombosis and bleeding. These 2 dragons are separate in most of the time, but when they are together, the situation is dramatic and disaster in most of the cases. That's why I found this very serious case to present. Long story short, 57-year-old woman with severe pain, numbness, and coldness of the upper extremity. 2 weeks ago, almost 2 weeks before index procedure, misdiagnosed as stroke or other neurology symptoms. This is usual situation, and the treatment was not adequate. You see the status. There's a CT angio which shows thrombosis of the left upper extremity at the end of the brachial artery. Doppler ultrasound confirms this. Nothing in the past, not usual concomitant diseases. Day 1, 3 days case. This is, you see, acute limb ischemia grade 2B, which in this slide shows urgent intervention. We decided as a team with the vascular surgeon team, we decided to start with endovascular intervention, mainly focused on thrombospiration. If there's not success, local thrombolysis and bailout surgery. Maybe in the discussion we should discuss if we would start with surgery first. This is the angio. You see the occluded distal brachial to the bifurcation and single artery through initial collaterals. That's why this is borderline case in accordance of time. We started to multiple attempts were performed to pass through this occluded segment, but with no success. That's why we changed our plan and went retrograde to establish the connection between occluded segments, and close the puncture with, this is our usual practice to stop the bleeding from the puncture site. Our intention was to use devices here, thrombectomy devices, and you see not so good result, because not so good result with angiojet aspiration. You see a lot of residual thrombus, and we decided to, many of you will say that it's risky, but it was a bank situation. That's why we placed the Craig-McNamara catheter with local lysis and waited till day 2. But clinically, the situation worsened, clinical situation of the arm. This is the complete opening of the brachial artery, but you see the distal, which is expected, but sometimes we have a very good result after local lysis, but not in this situation. As I mentioned, it's old occlusion, almost chronic. That's why we shift to our experience with stroke management with Sophia 5 French catheter, which is intended for stroke interventions. And after several interventions with Sophia and maybe smaller catheters, we achieved good flow to the wrist. But you see here extravasation, small extravasation, but small, but you will see. And waited till day 3 when the symptoms worsened, and you see the disastrous situation where everything is closed, and you see the stasis in the distal part of the hand, successful rewiring. We perform excessive thrombospiration with combined penumbra pump and Sophia catheter, and a lot of dark red thrombus, and achieved flow. But in every loop you see the successful result, but with extravasation. And you can appreciate the compression of the vessel. This vessel is not normal, it's like spastic, but it's compression. And clinically, you see distal flow, but continuous extravasation. You see the proximal part is, arteries are okay, but the arm clinically was not in good condition. That's why with vascular surgeons, they performed the compression and fasciotomy here and here, the compression, and this is the final outcome with saved distal part of the hand with preserved signal which were achieved in the cath lab. I forgot to tell you that the operation was performed in the cath lab, like hybrid room. And after you see the drop of the hemoglobin, but the condition is in this patient is improving. She had 2 plastic surgical procedures for correction of this big wound. And now I received information from yesterday. The hand is there, the woman is alive, but with contracture and significant reduction in finger sensitivity. She is upset of all of this, but she had a hand. Takeaway messages. This is Mars rover Perseverance, which is a symbol of this procedure, multidisciplinary approach with a lot of techniques which we are switching from other places and interventions, and very good communication between several departments in the hospital. That's why, thank you. Yeah, but in this
recognize the compartment syndrome if it's present, because any delay would result in function loss, even if the hand is reperfused. So the final good result is a good thing.
In that case, I will not be here if we started with surgical procedure, maybe, but the intention was to be endovascular in this situation. Thank you. Now, Dr. Stankov.